Okay, good afternoon. I do have top of the hour, so we will get started on time. Thank you for joining us today for the Project Echo Geriatric and Age-Friendly Care series on session on medication reconciliation. Dr. Rebecca Brynjolfsson will be our presenter today. I'm just going to go over a few housekeeping items before we get started, and then I will hand it over to her. If you have if you have a moment, please put your name, credentials, and email into the chat box. It's just a good way for me to kind of make sure I'm keeping track of everybody who's in attendance today. I did put links to the link to the pretest in the chat box. I will do that again now, just for anybody who's joined since the last time I've put it in. And there is a note in there about CME credit. If you're still waiting to receive CME or social work credits for attending any previous sessions, I do apologize for the delay. We are working on getting them sent out promptly. And again, I do apologize. Okay, and I will just be sure, I'm not talking well right now. Just be sure to please mute yourself. If you have a question, feel free to unmute yourself or put it in the chat box. I will monitor that chat box and make sure that those questions are brought forward to our presenter. And without any further delay, I will go ahead and turn it over to you, Rebecca.
Well, thank you so much, Julie. My name is Rebecca Brynjolfsson, and I'm a faculty member at NDSU in the School of Pharmacy. And one of my specialty areas is geriatrics. And so today I wanted to talk a little bit about medication reconciliation, which is not specific to the care of older adults, but is definitely important in the care of older adults. And so with that, we will start our presentation, and at the very end, we'll have a mini case series that will look at two different transitions of care for the same patient, one from home to the hospital setting, and then one from the hospital setting to the skilled nursing facility. So today our objectives are to describe medication reconciliation, to identify guidelines and evidence for medication reconciliation in and across various practice settings, and then to practice medication reconciliation through completion of a case series. When we think about terminology and the terminology medication reconciliation, it is important to consider the origins of medication reconciliation. And the origins, or this terminology, first appeared as a national patient safety goal in 2005 as part of the Joint Commission standards. So over time, this national patient safety goal has evolved to what you see on the screen in front of you. So National Patient Safety Goal 3 is improve the safety of using medications. And that goal is further subdivided into smaller goals. And one of them is maintain and communicate accurate patient medication information. And this is really what we think of when we're thinking of medication reconciliation. So this is recording and passing along correct information about a patient's medication. So finding out what medicines the patient's taking, comparing those medicines to new medicines given to the patient, give the patient written information about the medicines they take. Tell every patient it's important to bring their up-to-date list of medicines every time they visit a doctor. So this terminology and this phrasing is what is specifically found in the National Patient Safety Goals in the Joint Commission. And this phrasing appears in the following standards. So we see it in ambulatory healthcare, we see this in assisted living communities, behavioral healthcare, human services, critical access hospital, home care, hospital, nursing center, and office-based surgery. So pretty much no matter which setting you're in, it is important as part of your care for that patient is to improve the safety of using their medication. And one of the ways that we do this is through medication reconciliation. There are several other definitions that you can find of medication reconciliation. So the Agency for Healthcare Research and Quality defines it as reviewing the patient's complete medication regimen at the time of admission, transfer, and discharge, and comparing it with the regimen being considered for the new setting of care. It's also been identified in the literature as identifying and resolving unintentional discrepancies between a patient's medication list across the transition of care. So while there is no specific standardized process for medication reconciliation, we do see some commonalities in these descriptions that we've read so far. So from the Joint Commission, we see that it's improving safety, and we're that idea of improving safety and having an accurate list between transitions or in new settings of care is what's really core to medication reconciliation. And while there is a lack of standardized process for what it looks like, the processes that are developed by facilities are likely influenced in part by the individuals who are doing the reconciliation themselves. So at a minimum, medication reconciliation is creating that accurate list of medications. But in other cases, it's taken a step further. So we might think about medications reconciliation as a starting point for a more comprehensive medication review that occurs either by a specialized provider or by a provider as part of the patient visit. Both medication reconciliation and comprehensive medication review are really needed to use medications safely in older people. Medication reconciliation at transitions in patient care really does overall, again, contribute to the safe use of medications, especially in older people. So when we think about the 4 M's, you might also think about a 5th M, multi-complexity, but one of the M's is medication. And so we're looking at using medications safely in older adults, and that includes evaluating appropriateness. The other commonality we saw in those definitions was transitions of care. And so the Centers for Medicare and Medicaid Services defines a transition of care as the movement of a patient from one setting of care to another. Settings of care may include hospitals, ambulatory primary care practices, ambulatory specialty care practices, and long-term care facilities, home health, and rehabilitation facilities. I think one of the key takeaways from here is that we often think about transitions of care when patients are making really big transitions in our mind. So patients going from home to a hospital, or patient going from the hospital back home or the hospital to a skilled nursing facility. But transitions of care encompass even more than that. It can be transitions within settings in a hospital or health system, as well as transitions between specialty providers in an ambulatory setting and a general practitioner, primary care provider, internal medicine provider in an ambulatory care setting. So let's talk a little bit about the evidence for medication reconciliation. So my background is pharmacy. I am a pharmacist, and I would be remiss if I didn't say the evidence clearly does support the involvement of pharmacy in medication reconciliation. And we know that not every practice site is able to have a pharmacist involved in every area. So not all ambulatory care settings have a pharmacist in the clinic that can help to provide these medication reconciliations. But it is important to recognize that when possible, outcomes are greatly improved for those teams that incorporate pharmacy into the care of patients around medication reconciliation. So one of the first things that I wanted to just briefly discuss is this transition from hospital to ambulatory care. So the American Society of Health System Pharmacists and the American Pharmacists Association had a collaboration, and they identified some exemplar practices involving pharmacists in medication management and care transitions. And there were common features that they saw in these exemplar practices. So an interprofessional team approach, including pharmacy involvement, and then evidence of impact of intervention. So for the teams that were actually able to show the benefits or show that patient care was improved by doing medication reconciliation. And then also access to patient medical records. So over time, access to patient medical records has improved electronically. However, not all individuals still have access to all of the patient's medical records. So for example, in a pharmacy setting, a community pharmacy setting, it's not likely that the pharmacist has access to the patient's clinic chart. The same is true in a clinic setting. The clinic doesn't have access to the pharmacy's dispensing records. So those things can be challenges when we're looking at how do we reconcile medications when patients may be using them differently or getting prescriptions filled at multiple pharmacies or having multiple providers writing prescriptions. Some of the common barriers to implementation of processes were funding, staff, access to medical records that I talked about, and in general communication. So as with many things in healthcare, communication only improves the quality of care that we're able to provide, and communicating across transitions and across practice settings is always a challenge. And that's something that we can always strive to improve upon. This study I wanted to talk a little bit about is a study that was published in Research in Social Administrative Pharmacy, and it is a longitudinal medication reconciliation at hospital admission, discharge, and post-discharge. And this actually was a collaborative effort that was between hospitals and community pharmacies in the Netherlands. So again, our access to medical records may not be the same as the access there. Communication may not be the same as our colleagues in the Netherlands may have, but it was intriguing to me that the demographics for this study very much fit our older patient population, with an age averaging between 62 and 81 years and 10.3 medications at discharge. The thing that I found very interesting in this was that no matter what point you look at in medication reconciliation and this point in the process, there were issues that needed to be reconciled. So nobody's medication list was ever perfect at admission. And in fact, more than half of the patients had one or more changes that needed to be reconciled at admission. The same was true at discharge. So even though we may have reconciled these medications at admission, at discharge, there still had changes that needed to be made to reconcile those medications. And then at home, even though we had just sent the patient home, or even though the patients had just gone home with an accurate list that had been reconciled, 52.8% of patients had more changes, one or more changes, to reconcile their medications 5 days post-discharge. So I think this just goes to show that even though we have good intentions in healthcare of maintaining an accurate list for patients, that there are so many factors that can contribute to medications being lost from the list, or maybe not having a complete list to start with even. So one of the things we'll talk about as we continue our presentation are some strategies that have been identified as ways that we can improve our medication reconciliation and list. There are a lot of different reasons that are proposed for why patients have errors that happen upon admission, why they have errors in their medication list that happens upon discharge, and again, at home. So if we think about a few of those, at discharge, patients may have had medications that were held during the hospital that weren't restarted upon discharge, or they might have medications that were added at discharge that then had to be reconciled with the medications that were at home. Sometimes 2 formulary changes can affect this. So a patient might be on a specific medication at home, and in the hospital, that medication, a different medication in the same class may be on formulary. So they may be switched to the medication that's on formulary. And then at discharge, that all gets added back into the list. So patients might have duplicate medications. And we know that patients often get discharge counseling on their medications as part of the discharge process, but hospitalization is a very overwhelming time for patients. And so whether they recall all of the information that's communicated to them during that discharge counseling, or whether they clearly understand maybe isn't best assessed until later. And so here we see those 5-day post-discharge changes that need to be made, and that might reflect some of those types of issues as well. Ambulatory care transitions of care are also important to think about, even though we maybe don't think about these in the same way, especially if the transition of care happens within the same health system. The Institute for Healthcare Improvement reconcile medications in outpatient settings has some guidelines for how to do ambulatory care transitions of care. And so they recommend at the start of the visit to reconcile prescription medications, non-prescription medications, and dietary supplement use. And dietary supplement can include anything from herbal products to minerals, vitamins, anything that a patient is using that's non-prescription should be collected as part of this. And so there are barriers in that. There may not be a specific process that's used in your facility for how medication reconciliation is done for all patients coming in. It may be provider specific, it may be whichever individual is doing the medication reconciliation, it may just be specific to their process, but it's always helpful if you can have a process. The directions for use for all of these medications should be as complete as possible, and adherence should be noted. So even though a patient may have a medication on their list, if they're not taking it, should it be on their list is a good question, because that list will follow them to the next care setting. And perhaps it should be. Perhaps part of your process in that visit will be to educate the patient about the importance of using the medication. In that case, you would want to leave it on the list. But if at the end of the visit, you decide that the patient's not going to use that medication, or there are other changes that are made, it's great to reconcile that list right there to make sure that that list is most accurate. Discontinue the items that have been discontinued or that you would recommend being discontinued during the visit. So the goal is always to have the most complete and accurate list as possible. When we talk about hospital to skilled nursing home facility transitions of care, there was an article that was published recently that talked about lessons learned when discharging older adults to skilled nursing facilities. I thought they had a lot of really good comments and a lot of really good information to share. So again, this idea of completeness and accuracy being critical for patient care, we know that, and this just reiterates that again. One of the recommendations or best practices that they identified was making sure that patients have specific directions for all medications to be used in the care setting. So if in primary care, you're able to have a conversation with a patient and explain to them how to use a medication, and your directions on the prescription say use as directed, that may be sufficient for an outpatient ambulatory care setting. But when transitioning a patient into a skilled nursing facility or a facility where someone is going to help them to administer their medications, having it more detailed would be appropriate so that the medication gets used the way it's intended. So that's an example. So a topical product, for example. Other things that are important to think about for the care setting would be anything that's to be used as needed, making sure that that is specified. The accurate and complete medication list should be in the discharge summary coming from the hospital. So that's a good place to look for that to start with. But even though a list is accurate or complete, it doesn't necessarily mean that it's the best choices of medications for the patient. We still have to do some investigating and some considering on whether it's appropriate medication use for the patient population that we have. And then finally, if a patient is readmitted to the hospital, check for medication changes that may have happened during the skilled nursing facility stay. So just making sure, again, that you're including that stay as part of the transition if they go back to the hospital or even if they go back home. Stratus Health had a white paper that came out that had information on understanding and improving medication reconciliation between hospitals and nursing homes, patient safety risk and cost in care transitions. And one of the key recommendations that they had was making sure that all prescribed medications have a documented indication. And then also to use an interdisciplinary healthcare team that includes pharmacists. So again, making sure that we are thinking about all these medications as we're collecting them and putting them together in an accurate list, it's harder than we think it's harder than it seems like it should be. It seems like it should be pretty easy to keep track of this, but patients have different ideas on what is classified as a medication or what's not, or what's important to report versus what's not. And we know that no list is really probably completely accurate at any time. So keeping that in mind, I wanted to take the next 20 minutes of our presentation to talk through a medication reconciliation case series. I'll just pause here for a moment and see if there are any questions before we move on to the case series. All right. Well, I don't see any questions yet. Again, Julie's keeping an eye on that chat for us. So if you have any questions, please let us know. But I want to talk through just a few things that we can think about. And regardless of what your practice setting is, or regardless of your role on the healthcare team, everybody plays a part in keeping our medication list accurate for patients. So medication reconciliation, our mini case series, is going to have our first transition of care, which is going to be home to the hospital. So we have a 78-year-old ambulatory care patient who's admitted to the hospital following a hip fracture sustained from a fall in her home. So I have some past medical history here. The patient does have a history of osteoporosis, hypothyroidism, dyslipidemia, hypertension, mild iron deficiency, and she had a hysterectomy at age 54. She has no known drug allergies. Her CMP and CBC are pending, and her vital signs all look good today. So the first thing that we looked at for doing medication reconciliation for this patient was to identify the patient's clinic medication list. So if we go down through this list, we'll see the patient's on alendronate, 70 milligrams by mouth weekly, calcium carbonate, 600 milligrams / vitamin D3, 400 international units twice daily, ferrous sulfate, 325 milligrams, which is 65 milligrams of elemental iron every other day, levothyroxine, 75 micrograms by mouth daily in the morning, lisinopril, 10 milligrams daily, amlodipine, 5 milligrams daily, atorvastatin, 40 milligrams by mouth once daily, and Tylenol, 500 to 1,000 milligrams by mouth every 6 hours as needed. When we look at the medication list from the outpatient pharmacy, what is missing from this list? And don't look at the patient interview one yet, but just compare these two. What's missing from that list? Feel free to chime in, whoever would like to. So calcium and OTC meds, yes. So it's good to note that for the pharmacy, for an outpatient pharmacy, those medications don't get recorded for patients because there's no prescription generated for those. So those really are being recorded most accurately in the clinic medication list when we look at a provider's record. But realistically, when we look at the patient's list or what the patient tells us, that may end up being the most accurate record of all. So it's important to really know, if possible, what the patient is taking and not to just assume or select any of the calciums from the list, for example, that might come up, or any Tylenol or any iron supplement that's on the list, because those are potentially impactful for when a patient has an incident where they have to be transitioned from one care situation to another. And when we're making medication recommendations, we want to know most accurately what we can. So when we look at the patient interview, we see some other changes. So this patient has told us that she takes Fosamax once a week, and that's the brand for alendronate. So that matches up across the way. Iron every other day, that's on the clinic list. So I think we may not know, we may not have that information in front of us, but ferrous sulfate, so it seems like that matches up. She's taking a baby aspirin. That's not on the clinic list. It's not on the medication list from the outpatient pharmacy. And she's taking Citracal, which is actually calcium citrate, not calcium carbonate. And it's a different amount of elemental calcium and vitamin D than what we have listed in the clinic medication list. So it would be good for us to reconcile that. Now, there are some reasons for using calcium citrate over calcium carbonate. Calcium citrate is better absorbed sometimes in older adults than calcium carbonate. But we also have to think about how much calcium this patient is getting in her diet and whether she has adequate calcium intake. So, but it would be very common for a patient to potentially get a different kind of calcium than what we have recorded in the medical record. Seems like she takes Tylenol PM as needed. Now, if patient told you they were taking Tylenol PM in the clinic medication list, and you or whomever was doing the medication reconciliation didn't recognize that that's different, than the generic Tylenol that's already listed, that might be a potential missed medication that's listed. So Tylenol PM is actually acetaminophen and diphenhydramine together. And so that's good to know that it's different than what is in the clinic list. Torvastatin seems to be the same, lisinopril seems to be the same, amlodipine and levothyroxine seem to be the same. So in the initial transition, we're trying to come up with the most accurate list we can. And so I combined these together so that I had a reconciled home medication list. And this appears to be what the patient is taking based on what they've told us and what we have in the chart. Now, when the patient's admitted in the hospital, not everything on this list may be started. Can you identify anything on this list that may be held while the patient's in the hospital? And whoever would like to jump in and share, that would be great. So calcium, Tylenol, Tylenol PM. These are all good examples of things that may be held or may have a different, maybe written differently in the hospital, depending on what else the patient is started on or what the clinical course looks like. Ferrous sulfate also could be held in the hospital. Anything else on that list that seems like it could be potentially held in the hospital? I think, yeah, the Fosamax. Thanks, Anita. Fosamax could potentially be held in the hospital, or alendronate, depending on when the patient is taking it and or when they have last taken it, what the course is. And additionally, just knowing what we know about the use of alendronate, that might be something that we evaluate separately, looking at a medication review, not just is this accurate, but is it appropriate for the patient to still be on it, or are they in need of a holiday? You know, what happens? When do we decide that? And so this patient had a hip fracture, so I don't know that we would decide that right now, but in a patient that is admitted that doesn't have a hip fracture, that's been on it for a long period of time, we may start to wonder whether that's necessary to be continued, or if a holiday would be appropriate. All right. So then, while hospitalized, the patient had a total hip arthroplasty to repair the fracture. So they weren't able to repair it using screws. They ended up doing, yes, the hip fracture may not heal as well. That's a good point, June. While hospitalized, the patient had a total hip arthroplasty to repair the fracture. So now that the patient's been hospitalized, there are maybe a series of medications the patient was given during the hospital stay. We're not going to go through all of those in detail, but we're going to look at what may have happened or may be happening at that next transition of care. So the hospital to skilled nursing facility. So transition to hospital skilled nursing facility, this is the discharge medication list. So this is what the patient was discharged on. So looking at this list, it seems like there are two things that were added at the bottom: pantoprazole, 40 milligrams, and apixaban, 2.5 milligrams by mouth twice daily. So looking at this list, if this is the list that was coming in with a patient starting at a skilled nursing facility, what concerns might you have with this list? And anyone can jump in if they would like to as well. So we maybe talked a little bit about the alendronate. There may be some considerations you need to make with that. Calcium citrate, aspirin and apixaban. So together, both of those increase the risk of bleeding. Tylenol PM, diphenhydramine is on the Beers list. So we're not only looking at this from, is this medication list accurate, but we're also taking it a step further, right? At this point, we are reviewing, should the patient actually be on these medications? And so I think many practitioners over time do these things simultaneously, right? You're looking at something going, oh, aspirin's on the list, it shouldn't be. Okay, this patient is over the age of 70, they're actually over the age of 60 now. Our recommendations would say primary prevention over the age of 60 is really not indicated for aspirin use. So there are things on this list that are on the Beers criteria. So if we look down the list, we see diphenhydramine is on the Beers criteria, aspirin, potentially inappropriate due to age, pantoprazole, 40 milligrams by mouth daily. Now that wasn't there before. And we don't know that this patient is particularly at high risk of bleeding. It could be that this is a leftover from stress ulcer prophylaxis that maybe could be discontinued for this patient. And so that might be something you look at. Apixaban, 2.5 milligrams by mouth twice daily. So that seems appropriate given the information we have for the patient. And if we're discontinuing the aspirin, perhaps we feel a little more confident about having, well, we would need to have a patient on apixaban or some anticoagulant because of the recent hip replacement. But what's missing? What's missing from this list? Is there anything you expect to see that's not here? Or that is not as clear as it could be? Pain medication, yes. So this patient just had a hip replacement and they're missing medication for their pain management. And so that would be something that we would want to identify, because that we know that adequately controlling pain is very important for recovery for these patients. The other thing, I should just say, does anyone else have anything else that you identify that might be missing for this patient or could be clarified for this patient? Stool softener, yes. So if this patient is taking pain medication, for sure, a stool softener would be appropriate for this patient. The other thing that I would point out is something that was recognized in that article that I talked about with best practices for discharging from the hospital to skilled nursing facility. So making sure directions are as complete as possible. So in this case, we know the patient's on apixaban, 2.5 milligrams by mouth twice daily. We don't have any other information to know if this is the most appropriate dose for the patient based on their renal function. We didn't include that information for us today. But what we do know is that this is timed and limited to 35 days, that this medication would not be expected to be continued beyond that. And this is a good example of having a stop date with a medication if it's appropriate. So whether it's an antibiotic or whether it's a direct oral anticoagulant, anything that you know has a stop date, including that in the list, can help to make sure that it doesn't stay on the patient's chart and doesn't continue to be renewed over and over again as well. All right. It's also helpful to know when each med was last given. Yes, I would agree with that, Midge. That's very important. So knowing when the patient received them last, so really having clear communication from facility to facility, from one care setting to another, is very important. And when you're within a health system and you can access those records, that's really great. But when you have patients that are changing from one health system to another, that can be especially challenging. I think it's also good to keep in mind that with the pain medication, this is included on a hospital discharge summary, but pain medications, depending on which ones are prescribed, may need a separate written prescription. And so those need to be sent separately and make sure that they actually get where they need to be as well. So it should be on the discharge medication list, but you also need to have a prescription sent to the pharmacy that's filling those medications for the skilled nursing facility. All right. Well, we got through our case a little quicker than I thought we were going to today. So we do have some extra time for questions or comments. Perhaps we could have a little bit of time to discuss what what are some practices that you have found to be helpful with medication reconciliation with your practices?
Rebecca, Don Jervich
Yeah.
here. So I've used the ploy, or not a trick, but to mention that that bedtime tramadol dose might be contributing to memory loss and Alzheimer's disease, and which is true. There is some evidence for that. So that seems to start the conversation about whether they actually need to be on that medicine or not.
Yep. All right, so we've got some notes in the chat. So we have individuals who reconcile at every office visit, which is really important. Having patients bring their medications to clinic appointments. That is really helpful because sometimes it can be hard, pharmacy medication names are not easy. It can be hard to really fully understand how a patient is using their medications, but if you have them bring everything, so medications, over-the-counter products, any herbals or natural products into their appointment, you're much more likely to get an accurate list. It's hard to get patients to remember to bring those in, though, as well. And then how about the setting from swing bed to hospice? Okay, that's a great question. I'm gonna come back to that. Refilling or reviewing fill history from their pharmacy, and then having physical access to pill bottles by bringing them into clinic setting, helping to verify, eliminating duplicate therapy. Absolutely. So swing bed to hospice, I don't have a lot of experience in this area, Linda. I will tell you that specifically, but I do know that as patients transition to hospice, then you can start to think about what medications are appropriate for use as far as long-term. So when you look at torvastatin, for example, or using statins, the purpose of using a statin would be to prevent ASCVD events over a longer period of time. And so there is some evidence about discontinuing some medications that are more chronic medications that are used to prevent events when we know a patient's life is more limited and when they've entered hospice. So that's kind of my frame of reference for that. I do think that anytime you can document the rationale behind why you're discontinuing something, that helps for making sure that that persists from one setting to another if you do discharge or do discontinue something and you hope that it will remain discontinued. I don't know if that answered your question, Linda, but I do know that we do think about medication use a little differently when patients begin to enter hospice. Any other questions?
Again, please feel free to unmute and go ahead and ask a question, or don't hesitate to put it in the chat box. We do have a little bit of time before the session is supposed to be over, so any discussion would be great.
This is Madge at All True, and in some of our clinics, and we're hoping to get them in all, we have a pharmacist that works just in the ambulatory care settings, and they have collaborative agreements with our providers. It's really beneficial when it comes to dosing and different things, and the providers have that relationship with the pharmacist then, and they kind of get that trust in each other, and they're a great resource for us to have in our clinic. And if we have patients coming in that are especially if they've been in the hospital and a bunch of changes, sometimes we'll have that pharmacist meet with those patients when they come in and review those meds when they come in, and it's very beneficial.
Absolutely. I think anytime you can have pharmacists involved in it, when they're looking at information, it's any specialty area, regardless what group your specialty or where your specialty is, when you look at information in your specialty, you assess it slightly different than someone who isn't in that specialty. And so pharmacists are able to catch a lot of potential problems that could exist. And so it's really great when you're able to have that, but you're not always able to have that in the clinic setting. And some of our larger facilities definitely have access to a pharmacist that way. If you aren't in a larger facility, but you have a community pharmacist where you know that patient really works, or that pharmacist works closely with that patient too, they are certainly also able to help review medications with the patient and try to figure out what an accurate list is if it's not clear. So Karen, Karen asked, when a patient comes into acute care via the emergency department, does MedRec occur in the emergency department or once they're admitted to inpatient? So I believe the emergency department is considered a different care than once they're admitted inpatient. So they would attempt to do medication reconciliation in the emergency department. And then when they transition to inpatient, they would reconcile those medications again. And so who does the initial med rec really depends on the setup of the facility. So if there is a pharmacist in the emergency room, that pharmacist might be involved in the med rec process. If there's not a pharmacist in the emergency room, it may be nursing staff that is involved in that as well, or I shouldn't say nursing or other staff that are involved in the med rec process. So the goal, though, is to try and find out as quickly as possible what medications the patient's taking, because in an emergency setting, an emergency situation, that can really impact your ability to provide care for that patient. And it's maybe more challenging in an emergency setting if the patient is not able to communicate that with you and you don't know where their pharmacy is. So it may be more acute in that case. As far as how do you handle herbal supplements and those interactions, a lot of clients don't feel like these are a medication and fail to mention these. I think that is very true. So there's been some research that's been done. I don't have a specific citation for you, that patients tell you what they want to when you're doing medication reconciliation. If they feel like they don't want to tell you something because perhaps they wanted a prescription from you and you explained to them and had a conversation with them that you didn't feel that that was appropriate yet, and they went somewhere else and got it, they may decline to mention that to you when they come back to see you. They may also think that if it's natural, then it's not necessary to include it. And because there are so many interactions that occur with herbal supplements, I think just reminding patients that even though they're herbal, they can still potentially interact with their medications. And so having them bring everything is still good. And you may not be able to change their minds that they don't perceive that they're a medication, but making sure that they do understand, especially if you know you're going to start them on a medication that has known interactions with herbal products, that you're asking about those. So I always think when you're starting patients on anticoagulants, especially, I always am asking about herbal supplement use, because those can really increase the risk of bleeding in some cases. And patients don't think about that the same way we do. Again, I just keep coming back to that idea that medication reconciliation is really one part of the process, but it's still, we can have a really accurate list of medications that can still be wrong for the patient. So we can have accurately what the patient's taking, but unless we as providers take that next step and try to avoid potentially inappropriate medications and identify medications that may not contribute overall to safety for our patients. Do I think dentists are remiss to not try to do medication reconciliation? I think any provider that is prescribing medications should be doing medication reconciliation. So if dentists are not doing that, I would say I think that that's a missed opportunity, because there can still be significant interactions that occur with the prescription or with prescribing, especially thinking about pain medications or antibiotics when used for dental procedures. There's still potential for interactions. Any other questions?
I'm not seeing anything come through the chat. Here we go. We've got something in there now.
Okay, so we have a participant who's commented that in the state of Missouri, all HH, I'm not sure I know the abbreviation for that, but personnel are required to do medication reconciliation prior to initiating home health. Thank you. That makes sense. Let me say it. Prior to initiating their treatment, regardless of the time it takes. It's the number one reason for hospital readmissions in the state. I do think that those mistakes, and I don't want to say they're mistakes because I don't even think they are errors that happen, but many times what we see with medication reconciliation, I think, is that things are inadvertently lost, or things are, it's not an intentional error that's happening. It's something that's unintentionally lost, or an unintentional harm that could happen. Yeah, that is really good to see that medication reconciliation is a priority. It does take a lot of time though, and especially if the individuals who are really helping with the medications aren't available to help in part of that process either. I think that's a good point to bring up for older people when we're working with older adults who may or may not have the ability to report their medications accurately. Having someone who can help them to report their medications accurately or can write down what's being used for them is really important, because we know that not all of our older adult patients will be able to provide an accurate medication history. Not even all of our younger patients are able to provide an accurate medication history.
Anybody else has any comments, questions, unmute, throw it in the chat. I will go ahead and put the links to the post test and the evaluation into the chat right now. If you can, and if you don't get to them while they're in the chat, I will be sending out an email with links to that as well. And I will also go ahead and put the link to the online registration. Coming up in October, our next session is going to be psychosocial and spiritual needs. And that's on October 11th at Tuesday, October 11th at noon. I'll put the link to register in the chat box as well. And in the meantime, let me check and see if there's other questions that have come through. I'm not seeing anything right now. And there's the registration link for the upcoming session in October. Again, I know I had mentioned this at the beginning of the session. If you are waiting to receive any type of credit, it is coming. I understand right now it is a slow process and probably a little frustrating, but we are working on it. And I do appreciate your patience. And in the meantime, do you have anything else for us today, or do you want to wrap up?
I don't think I have anything else. So if there are no more questions, thank you so much for your time today. And I'm happy to answer any questions you might have.
Okay. And I will leave the chat box open for just a few more minutes, but feel free to, if you've got what you need out of the chat box, go ahead and log off. I think we can probably call it a day for this, but I will leave the session running in case you need to grab those links for a minute.